So welcome everybody to today's doctor's talk, aortic stenosis and post-acute care at St. John's Rehab. It's hopefully we get to the last part because that's the part that involves everybody else, especially on A1. So I have no grants, research support, speaker bureau, honoraria, or consulting fees regarding this topic. So aortic stenosis, the demographics is in over 65-year-olds, 2% of the United States population, which I think we can extrapolate to Canada, suffers from this condition. Aortic sclerosis is 29% of the US population over 65 years. And aortic sclerosis will progress to aortic stenosis in 50% of those cases. Aortic sclerosis has a greater mortality in 50% of cases, but it will progress to aortic stenosis in 9% over 5 years. So what causes this? The most common cause is age-related calcification of the aortic valve in developing countries. The second most common is rheumatic fever, especially important with our immigrants from first world countries, and congenital abnormalities, which is a little less common, things like bicuspid aortic valves. So the calcific aortic stenosis is the most common one. The prevalence is the most common acquired valvular disorder found in developed countries. It increases with age, and 12% of the population has mild to severe aortic stenosis, and severe aortic stenosis is 3.4% of the general population. This is what the diseased valves actually look like. The signs and symptoms, the three major ones are heart failure, angina, and syncope. And the diagnosis, a lot of you might have heard of carotid parvis et tarvis. It means there's a delayed upstruck when you feel the carotid artery. And if you're listening to the heart sounds, you may hear the sound first and then feel the pulse later. Whereas in normal people, you hear and feel at the same time. You get a laterally displaced apex beat, a soft second heart sound, the classical crescendo, decrescendo systolic murmur, and the actual intensity of the murmur is not as important as the timing, which predicts the severity. This shows you why it is so important to treat aortic stenosis. If it is diagnosed with one of those symptoms, angina, syncope, failure, you have 2, 3, or 5 years average survival. So treatment is very, very important. The 5-year survival for breast cancer, 23%, lung cancer, 4%, colorectal cancer, 12%, prostate cancer, 30%, ovarian cancer, 28%, and severe inoperable aortic stenosis is 3%. So you can see this is a serious illness. If it were a cancer, aortic stenosis stage 1 would be no symptoms, no damage, just picked up incidentally. Stage 2 would be left ventricular hypertrophy, stage 3 left atrial enlargement, stage 4 pulmonary hypertension, and stage 5 right ventricular failure. And if you remember from the previous slide, there's like a 2 to 3 year survival if no intervention. So diagnosis, auscultation, like I described before, cardiac catheterization, electrocardiogram, chest x-ray, but the gold standard is the transthoracic echo. And technically, I'm not going to explain all this, but that gives you the diagnosis, the numbers you get from the echo. This is a very busy slide, but basically what it's saying is no matter what stage or condition or timing you find aortic valve replacement, the recommendation is treatment. This slide didn't come out so well with the explanation, but basically what it's saying is that without treatment, you have a very poor prognosis and you can change the gradient of the slope with treatment. Early aortic valve replacement against doing watchful waiting. Asymptomatic patients have a lower operative risk because they're not sick yet. So some people believe you should go for early aortic valve replacement. Potentially, you could reduce the risk of sudden death. You could prevent the irreversible damage to the myocardium and eliminate the risk of irreversible complications. People who believe you should watch think the risk of death with conservative treatment may be low, needs more study. Close follow-up can identify who should undergo the aortic valve replacement at what stage, and that avoids the risk of the procedure and the morbidity and mortality, and also avoids the risks of long-term complications such as anticoagulation or endocarditis or reoperation. So the treatment for aortic stenosis, basically two different treatments. Transcatheter aortic valve replacement, which is a newer procedure, and we do it now mainly on patients that are found to be inoperable. The mainstay the mainstay treatment up to now was surgical treatment with a thoracotomy or just a minimal incision, and we see all of these on A1 post-surgery. The inoperable patients are, they could be old age, greater than 85 years, they could have had a stroke, reduced ejection fraction, had a CABG before, history of atrial fibrillation, thoracotomy in the past, fatigue, slow gait, peripheral vascular disease, frailty, syncope, calcified aorta, chest radiation in the past, coronary artery disease, COPD, renal insufficiency, diabetes and hypertension, and these are all self-explanatory, really. So I'm just going to play a little video clip of what they actually do during surgery.
Now let's discuss your procedure. After your anesthesia takes effect, the surgical area will be scrubbed with a special disinfectant soap and may also be shaved. Your surgeon will then make a 6 to 8 inch incision down the middle of your chest. Your breastbone is then separated, the heart sac is carefully pulled back, and your heart is examined. At this point, you will be given a large dose of a blood-thinning medicine called heparin to make sure that your blood does not clot. Your surgeon will then connect your heart to the heart-lung bypass machine with a plastic tube. Blood from your heart is then sent to the bypass machine through this tube. The machine supplies your blood with oxygen and then pumps it back to the rest of your body through the other tube. While connected, your blood simply bypasses your heart and your lungs, but still reaches the rest of your body. After the heart-lung bypass is established, your heart will need to be cooled to keep it still. Then, the aortic valve replacement procedure can begin. The aorta is gently opened to reveal your aortic valve. Your surgeon will then carefully remove the old aortic valve. At this time, your doctor will then select a mechanical or tissue replacement valve, and this will be sewn into place with stitches. Once securely in place, the aorta will be closed with stitches. After this is done and your heart regains strength, you will slowly be removed from the heart-lung bypass machine. You will be completely free of the machine when your heart resumes its normal function and can support your body with its own pumping ability. Because everyone's heart is different, the time it takes to be removed from the bypass machine varies. If your heart is slow to return to its normal function, several options are available to help it regain strength. These include medication through your IV or...
Okay, it's a little simplistic, but none of us are heart surgeons here. So types of artificial valve during this surgery, we have mechanical valves, which are synthetic material. They're very durable, and bioprosthetic, which is usually animal tissue. The choice depends on how long you think the patient is going to live for and the ability to tolerate anticoagulation. So here's just what the valves actually look like. These are mechanical valves. And these are what they're developing in the future. The bioprosthetic valves could be xenograft valves, which mean they come from a different species. Could be from cadaver tissue from a human, homoallograft, or autograft. Means they take from your pulmonary artery and put a prosthetic valve in there and use your pulmonary artery for your pulmonary valve for, and as an aortic valve replacement. Usually it's xenograft. The difference between the two, the mechanical valve will last about 30 years, the bioprosthetic 10 to 15 years. The mechanical valve has more chance of clotting, thrombus, bioprosthetic less chance. The noise is much more with the mechanical and less with the negligible with the bioprosthetic. And anybody who's ever listened to a mechanical valve can hear a click. In fact, the patients, when they go to sleep or when everything's quiet, sometimes they complain that they're hearing a click. The valve deterioration, the mechanical valve is very durable. That's why it lasts for 30 years or more. Bioprosthetic, highly susceptible. Hemodynamics, mechanical valve is improved, but the bioprosthetic is close to natural. Anticoagulation with the mechanical valve is lifelong, and it's very strict. INR. Bioprosthetic, usually for aortic valve replacement that we get, we don't anticoagulate with Coumadin, but the bioprosthetic mitral valves are for about 3 months. The risk of reoperation is much less for mechanical and for obvious reasons, higher for the bioprosthetic. Because the incidence is in the elderly patients, the ones that we see the most here at St. John's are the bioprosthetic. Selecting mechanical bioprosthetic, if you're over 65, you go for bioprosthetic, less than 65 mechanical. If the person is getting anticoagulated anyway, if they got atrial fibrillation or something and they're on Coumadin, then you would go more for mechanical. They're being anticoagulated anyway. If there's mechanical valves at other sites, such as in the mitral or tricuspid area, you would go for mechanical. Women of childbearing age, they say bioprosthesis because of the anticoagulation. As I said, the atrial fibrillation, hypercoagulability, and anything you may be on Coumadin anyway, to go more for mechanical. And the small aortic annulus is better with the stentless bioprosthetic. So that was surgery. The other alternative is the transcatheter aortic valve replacement. We see a lot of this on A1 as well. And instead of doing that surgery that I just showed the video clip, all it is putting a little catheter into the heart directly or into your femoral artery in the groin. It's less invasive. There's two options. The first one there, the Edwin Sapien, it's balloon expandable, and this other one has a very special metal that is self-expanding. They leave it there, it self-expands, and that's the more common one nowadays. Transapical, we don't see that many of these, but they go directly through the ventricle there, and you can see the catheter with the valve expanding in this little cartoon. transfemoral. They go from the groin in the opposite direction, the femoral artery, and they thread it all the way up and expand the valve from the opposite direction. That's what it actually looks like. That's a photograph. And that's how they follow it with fluoroscopy. They X-ray it all the way along. So selecting these patients, the hospitals all have their own little TAVI clinics, and the cardiologist or internist refers the patient there, and then the patient's reviewed by the surgeon or the interventional cardiologist. Most of the TAVIs in Ontario are done by surgeons, but interventional cardiologists do them too. And they have a whole team and TAVI rounds and come to a decision whether it's going to be surgical or transcatheter. Limitations of this procedure is death, myocardial infarct, stroke, bleeding, vascular access complications. You can get pseudoaneurysms in the groin. You may land up with a permanent pacemaker. We see that all the time. Afterwards, it used to be much more common, but perivalvular regurgitation. So you would go from aortic stenosis to aortic incompetence after this procedure, but it's much less common now. Structural deterioration of the artery, need for antibiotic prophylaxis afterwards, just like any prosthesis, and small risk of valve thrombosis very early on, which could be fatal. In Ontario last year, there were 700 TAVIs performed across Ontario. TAVI centers are, like Sunnybrook, are funded for a set number of volumes, but some centers are using foundation money and research money to increase their share. The Ministry of Health is aware that this is an increasing procedure and will continue to increase. If a patient is over 80, usually they get a TAVI automatically instead of the surgery. After the TAVI procedure, you recover in CCU, go down to the ward, you reassess 4 or 6 hours later, and the average discharge for a TAVI is 1 to 2 days post-procedure. If the patient is deconditioned, they may require inpatient rehabilitation, and we see a lot of patients in A1. Follow up with family physician, nurse practitioner, and cardiologist 6 to 8 weeks later. I bolded and underlined the important one. So the patient goals after a TAVI are quality of life, some of them realistic: stairs, walking, curling, Scottish dancing, skydiving. The goal is to reduce hospital admissions, resume social activities, spend time with family. And I included patient goals because we should include patient goals in everything we do. What about the low-risk young patients? The answer is on the first line. The data is lacking, but it is becoming more and more common, and it is probably the wave of the future where surgery will be the minority and the TAVI will be the majority. I just put this slide in to show you the age 85 and over strongly favors the TAVI, and then the complications you can get with the different TAVI or surgery. Deaths seem to be fewer with the TAVI, strokes seem to be fewer, reinterventions seem to be much more common with TAVIs. Pacemaker insertion also much more common with TAVIs. Life-threatening bleeds, fewer with TAVIs, that makes sense. New onset of atrial fibrillation, fewer with TAVIs. Heart failure following, fewer with surgery. Aortic valve reinterventions, fewer with surgery. And hospital stays are fewer with TAVIs. So the takeaways are that it is a very prevalent disease, very serious disease, and intervention is mandatory. They believe that TAVIs are the future and will be probably with all patients, including the younger, lower risk patients in the future. There's ongoing investigations, that's for the future. Minimally invasive therapies such as mitral clips and other interventions are coming, and we're actually seeing them too. So what do we do with these patients at St. John's Rehab? And this is an interprofessional team approach, and these are the actual words of our therapists, nurses, pharmacists, physiatrists, doctors, hospitalists in our unit. So excuse the spelling mistakes, they're not mine. Except for this one. So the hospitalist admits and writes the orders. He or she looks at the symptoms, pain control. Anxiety is very big in our population, and manages all the comorbidities. We have a lot of diabetes on A1. We involve other specialists, physiatry, psychiatry, geriatrics, urology. Daily monitor CVS status, rhythms, blood pressure changes. Volume overload is a constant issue on A1. We use a lot of Lasix, a lot of metolazone on A1, more than anywhere else in the hospital, I'm sure. And wounds are very, very important in this population, especially the dreaded sternal wound infection. In fact, when we see that early, we send the patient out straight away. And I don't know if anybody has worked on A1 and seen any of these wounds when they come back to us. They usually have a vac dressing, and if you look below the vac, you can actually see the lungs going up and down. It's quite a sight. The physiatrist, Amanda, provides specialist inpatient cardiac rehabilitation services. She delivers consultations, assessments, management, discharge safety and planning, and post-hospital care and rehab. She functions as a resource to myself, to the rest of the crew, the family physicians, the referring cardiologists, the internists, the cardiac surgeons. And on A1, we have a shared medical model of care between the two of us. The dietitian, that's Melissa. So the dietitian provides therapeutic nutrition support and nutrition education with healthy heart eating, assesses the patient at increased nutritional risk, patients who have experienced weight loss, poor intake, appetite, wounds, etc., and develops individualized treatment plans to help patients improve their nutritional status. So I warned Melissa that I was going to tell everybody that I attended a conference, Hospital Medicine 2018 this year, and one of the talks was titled, Things We Do for No Reason. And the healthy heart diet was under the microscope. Apparently it's very controversial whether a low sodium diet works or does more harm or not, or whether fluid restriction works or does more harm or not. It needs more RCTs, and I think Melissa and I have agreed that we're going to do a study on this. And maybe we can solve this controversy. The physiotherapists, that's Pauline and company. The cardiac patients attend cardiac class 6 days a week, consists of 30 minutes sitting, standing exercises, 30 minutes of education. If anybody has been on A1, they know we have a cardiac class every day, and the different professionals do different things with the patients different days, but the therapist 6 days a week. The education is provided by an interdisciplinary team, which is what I just said. The exercises are designed specifically for cardiac patients with sternal precautions, pacemaker precautions as applicable. And I encourage everybody to find one of our wonderful therapists, physiotherapists, and help them to, let them help you understand what the sternal precautions are. Cardiac patients are also engaged in a walking program, progressing their walking endurance, practice stairs as needed. Heart rate and oxygen saturation are monitored during exercise and ambulation. And I think that's unique to A1. Energy conservation is reinforced. Patients are progressed in their walking tolerance and encouraged to walk 30 minutes a day. Upon discharge, they ensure that the patient has the proper equipment, and most importantly, they're referred to a cardiac outpatient rehabilitation program, which we do not have at St. John's as yet, but maybe in the future. Nursing, Janille, I don't think Janille is here, and her gang. Say a registered nurse or registered practical nurse performs assessment that includes monitoring of vital signs, pain management, wound care assessments, capillary blood glucose management, especially if diagnosed with diabetes. Patient lab results, INRs are monitored, weights are measured, usually every second day as ordered by the physician, but that's standard. If there's an increase of 1 to 2 kilograms, the doctor is notified. The nurses, most importantly, educate cardiac patients on healthy lifestyle habits such as smoking cessation, nutrition, energy conservation at the bedside, or the nurse's day at cardiac classes on Tuesdays. Most importantly, daily nursing care and assessment and wound care, as I said before, is very, very important in these patients. Social worker is Woody here. So the social worker sees the cardiac patients on a referral basis, and he gets that through team rounds, referrals from other team members, or requests by patients or their families. He conducts psychosocial assessments, provides supportive counseling, assists with accessing financial help through appropriate government programs, assists with TRILEAFLET drug program, facilitates transfer of the patient to respite accommodations such as retirement homes or Pine Villa, which is our very own Sunnybrook program, provides community resources such as homemaking agencies, and arranges and facilitates family team meetings as needed. He also facilitates group classes on stress management twice a week. And that's also in the cardiac class. The occupational therapist, and this is Karen and team. Is Karen here? Yes, yes. OT educates on cardiac precautions, energy conservation principles through cardiac class, helps the patient achieve independence in functional transfers for toileting, shower and bed mobility and car transfer, recommends equipment such as bathroom safety devices to ensure clients can, meaning patients, can safely return to or remain at home after their inpatient cardiac rehab, assesses the cognitive impairment and helps them manage cognitive issues related to their activities of daily living. After discharge, they provide and refer community resources such as CCAC, homemaking, transportation, and Lifeline. Pharmacists, I see Grace here. I think Wendy's away. They come to, they say that the patients come, and this is true, come to cardiac inpatient rehab after recent heart surgeries and are often on a vast array of new medications. They frequently feel overwhelmed with the quantity of medications and the information that they are given. And after having such a major surgery, a lot of the patients even say to me, but I wasn't on these medications before. The pharmacists help the patient understand the new medications, how to manage them, increase adherence to the medications, discharge through education, addressing concerns, making suggestions of how to manage at home. Examples are blister packaging, dosette boxes, rearranging administration times if needed. They also educate the patients weekly in the cardiac class, including medications such as the anticoagulation, which is very important for the aortic stenosis patients, warfarin, insulin, diabetes, and their discharge medications. Every single cardiac patient gets an individual discharge counseling from the pharmacist. In addition, the pharmacist helps us out by reviewing medications for indication, dosage adjustments, duration monitoring, and makes recommendations to the medication regimen. That's the in-hospital doctors, as well as resolving any ongoing issues and concerns by liaising with the transferring hospital specialists and rehab physicians. Thank you. Any questions for myself or any of our team on A1, actually?
Deputy, I noticed you mentioned anxiety as part of the problems that these patients have. Is it anxiety because of all of the medications and stuff they've gone through, or is it related to other things, or they're afraid their heart valves are going to stop working? Do you have a sense of what's...
So after cardiac surgery, whether it's CABG, valve replacement, whatever, it's such a massive surgery that the patient comes into touch with their mortality. And there are actually some psychiatrists that have made their niches cardiac psychiatry or post-surgical psychiatry. And actually Rosalie and Matt are really, really helpful and involved with a lot of our patients.
You mentioned several times about energy conservation was important, but then you're, on the other hand, we're talking about 30 minutes of walking every day, and they might be skydiving and stuff. So I don't understand the energy conservation side.
So the patients could walk, we could make them walk 3 hours a day, but we're only doing it 30 minutes a day. But I can see if one of our therapists will explain that.
But you can't expect them to do what they used to do, right? So we sort of would do an activity and then rest. So we find even people, after they get rest, they have to take a rest. Then they go take a shower, they rest. And they take a walk, they rest. And we want to ensure that when they go home, they follow the same sort of guideline. Because when you go home, you're not having your meals planned, right? So you may have to go home and say, I'm going to make a light meal, then I'm going to sit and rest. I'm going to fold some laundry, I'm going to rest. I'm going to entertain one visitor, and then I rest. You know, we encourage them not to have a ton of visitors, right? So it's just a philosophy that if you follow the energy conservation principles of doing activity and rest, you'll be stronger than just doing a lot at one time.
And it's good for your heart.
It's good for your heart because you'll do more, but then you'll take rest and retreat.
And I want to clarify what we're walking. The 30 minutes is the ultimate goal.
Yeah.
Right after surgery, we usually start with like maybe 5 minutes each walk, but 6 times a day.
So it's a slow build up, right?
Yes, and that a minute each day.
As you get fitter.
Yeah, what about the risk of infection? I know, like I hear you're supposed to get antibiotics if you get a dental procedure, and any invasive procedure you're supposed to get antibiotics because of the risk of seeding infection on these valves. Is there a difference between the different valves, the TAVI versus the mechanical versus the allograft?
I think that it did say that the mechanical valves are more prone to endocarditis than the bioprosthetic ones.
And do you end up giving them prophylaxis for things that happen on the floor, or is that more like other things?
Not on the floor, but we give them for dental procedures.
We usually see them in discharge summary, you see prophylaxis or not.
Yeah.
Okay.
About the INR and the blood thinners regimen, what's the difference between the TAVI one versus the mechanical one? Well, we already heard from you about the mechanical valve versus the prosthetic valve. But what's the difference between those two groups versus the TAVI prosthesis?
So the TAVI, they would use anticoagulation with Plavix or aspirin, but they don't use Coumadin. And it's they said that it was rare for the valve to thrombose, but it happens and it could be fatal right in the beginning. But they said it was very rare. But there is no Coumadin INRs with the TAVIs.
A lot of seniors like to take calcium supplements. Okay, what are your thoughts?
On calcium supplements?
Yeah.
Amanda, what do you think of calcium?
There was a recent.
Or actually, Melissa.
There was a recent New England sort of big article, I think it was within the last year or two, suggesting that it's better to get calcium in your diet. So
Exactly, yeah.
often we'll pull in Melissa because it's more absorbable, and whereas we used to always give calcium carbonate to everybody, but there is some evidence that maybe that just weighs down on your aortic valve.
Yeah, no.
And we used to actually give everybody calcium carbonate twice a day, and now it's once a day, maybe even.
Yeah, I'm trying to get through diet.
Yeah, so we usually, especially if we have like a hip fracture patient, and we don't get them to have anyone, but I'll usually just ask Melissa to see for dietary advice first as a first line.
And that's what I do in the falls program. Because I'm just wondering, even before they get this problem, people taking calcium supplements, maybe there should be more out there.
Do you set up to an outpatient cardiac program after the
Yeah, so all of them are they're asked whether they want to go or not, but every one of them is offered one and strongly suggested.
And how long is that program usually?
I think it's 6 weeks, right?
Depends on the program. So there are anywhere from 3 to 6 months. I mean, we have the luxury of Rumsey being very close to us, the Toronto Rehab program, and they actually have like a graduate program where people can join and become a yearly membership and still use the track in terms of resistance training. And all the programs will start after the sternal precaution. So they'll usually see their cardiac surgeons 6 to 8 weeks out, and then they'll put them, because all the outpatient cardiac rehab programs will have the walking, but then also add on resistance training, which we're not able to do on A1 because of the sternal precaution.
We were actually maybe a couple of years ago thinking of starting an outpatient cardiac program here at St. John's, but something happened. It never took off.
Jeffrey, now that we see how bad it is to have aortic stenosis, we're all thinking about what can we do so we don't get it ourselves. And for atherosclerotic heart disease, you kind of know control hypercholesterolemia, control diabetes, diet, those things. What about for aortic stenosis? Are there things that the average person can do to reduce the risk of developing aortic stenosis?
So I didn't see anything for prevention. In fact, they seem to say it's a natural progress of aging, and you get more calcification of the aorta as you go along with the aortic sclerosis. But yeah, that's an interesting question. I'll have to look into that.
I think I can help you there. I think maintaining good blood pressure is very important, not necessarily for stenosis, but certainly for aortic insufficiency. And the afterload reduction that you get from taking blood pressure down is significant. It's less stress on it. I think if you've got a valve that's already stenotic, you're going to have even more issues with aortic insufficiency, both in bad.
But they will, earlier in the talk, I said they will treat most cases, not just manage conservatively.
Most cases of aortic stenosis.
Yes.
The mechanical valve only lasts like 30 years and the other one only 15 to 20. Do they replace the mechanical valve with a mechanical valve?
I mean, that's an interesting question. I would presume that if the patient was at a certain age that they didn't expect much longevity, they'd go for a bioprosthetic. It's less maintenance afterwards.
We have also seen reduced errors.
Yeah. And with a TAVI, it's actually much easier to do a redo TAVI. They just go through the original TAVI and open up another one. Okay.